Hello and welcome to Healthline 3. I'm Terry Simmons. Today we're talking with Dr. Michael McGalley of Willis-Knighton Cardiology. We're going to be talking about the advances in treating complex coronary artery disease. We'll be taking your calls throughout the show, and as a reminder, please make sure you're in a quiet room with your TV turned down all the way so we can hear you and you can hear the answers to your questions. The number to call is 318-219-4569, and you'll be able to see it across the bottom of your screen throughout the show. Thank you so much for being here, Doctor.
Thank you, Terry. It's a pleasure.
Oh, it's our pleasure. This is fascinating to me, and I'm sure to a lot of our viewers, because it's all about complex coronary disease and artery disease. And we're going to talk about how, we were talking about earlier, you and I off camera and on camera early this morning, about how coronary disease, heart attack, it's all a big umbrella for a lot of specific terms that we can talk about today and kind of redefine what's going on with all the things that you may hear about generally when you go to the doctor or you wonder about. So let's talk about what this complex disease means first.
Well, it's a great question, and I'd start by saying that coronary artery disease is very, very common. It's like, again, the most common cause of death. And, you know, we have gone a long way in treating those. And that coronary artery disease, it's exactly as you said, it's an umbrella for a lot of terms. So it includes this disease that is acute, that comes acutely, like heart attacks, and you go to the hospital, and it's a lot of times life-threatening. And also encompasses the other spectrum, which is, you know, stapling, you just get chest pain when you walk, shortness of breath, all that. And this disease, both spectrums can range from being just easier to treat to difficult to treat to what they at some point called impossible to treat, or there's no option. And it's a new field in interventional cardiology to be able to treat what was supposedly not treatable or very, very, very hard to treat. And that is what encompasses the term complex coronary artery disease.
Right. And we were talking about earlier, it hasn't been too long ago. This has really been in the forefront. We're hearing a lot about this. And it's alarming at first. You might think, oh no, there's more people are getting coronary artery disease or having these problems, but that's not true. The reason we're hearing about it, and I really want to stress that again, is because there's so much advancement in the treatment, which is really what we want people to know today, right?
That is very true. Like, this started years and years and years back with coronary artery disease. It started by treating it with just a balloon and mainly surgery for a long time. And with time, stenting had come out and a lot of techniques had come out to treat it. But still, it was very limited in treating a lot of these diseases, like exactly as an example, when they are very calcified, they have a lot of calcium, this is very tough to treat. When they have multiple vessels, this is very tough to treat. And we're going to talk about this, the arteries that are 100% occluded, what we call chronic total occlusion. This has been like a place of no-go for a long time. And as you said, in the last, 2 decades, there's been a lot of advancements in treating those. That's why they are being brought into attention. That's why we talk to patients and tell them, well, you still have other options other than surgery, and even if surgery is not an option, we still have a final option to offer right now, these days.
It's hard to believe that it wasn't that long ago where people were told, I'm sorry, there's not any more we can do, and they were sent home, right? There just wasn't.
Yeah, and the sad thing is there still some people, they still are told that they have no option, but because the knowledge that this advancement has happened and is there is not out there yet. And it's an important thing to bring attention that having no option is probably a term of the past. We hope still there will be a very, very little percentage of people that really have no option, but now we can offer options to a lot of people.
And that's amazing, I'm sure, and so gratifying to you and your field here to help other people to know that you can offer, even just having the conversation to tell someone there are so many options we can try.
Yeah,
it's got to be.
Yeah, it is
amazing.
Very gratifying. That's why I went right straight to that to that field. So I went to Detroit and Henry Ford Hospital to train specifically for treating complex disease and chronic total occlusions, and it is actually one of only 5 programs in the country.
Yeah, you were telling me about that. Let's talk a
Yeah.
little bit about the program, because you have been to Chicago, Arizona, Detroit. You've trained in this specifically all over.
Yeah.
So tell us about the program.
Well, as physicians, we train a lot.
Yes, yes,
Yeah,
all the
but,
time.
interventional cardiology is a specific one-year training, and I did that in Arizona, but having another extra year of specific training to do a lot of these complex cases and chronic total occlusions was a privilege. So I went to Detroit, and throughout the year, we only did these cases that were referred to us from everywhere, Ohio, Michigan, everywhere.
Right. Well, I think we have a caller for you. Jerry, thank you for calling. What's your question?
Well, how you doing?
We're doing great.
Good.
How are you?
How are you?
Well, pretty good. I have a question. A person who is a diabetic, and they have low sugar, and they sit there and have a seizure. Does this, if you have a bad heart, does that affect your heart or not?
Well, that's a great question. So, if I'm understanding correctly, you're saying that having a seizure from low sugar, does that affect your heart or not? Correct?
Yeah. If you have a bad heart.
Well, having a bad heart, I mean, that gives you a very low threshold of tolerating a lot of things. And seizures are a very stressful event on the heart and the whole body. So I would say it would not be the best thing. It can induce a lot of bad things like heart attack or something. Although this might not be very common. The best thing is to not get sugar get too low and not to have a seizure, of course. But yeah,
Well,
it can affect it for sure.
Yeah, well, see, I had a bad heart attack 2014. I was in ICU for 18 days, and
Wow.
I am a diabetic,
Wow.
and I did have a seizure. Yeah, I did have a low sugar, and I finally laid there for about an hour and a half going through the seizures and stuff before anybody realized that I was having a problem.
Wow.
And then I got sent to the emergency room, and I was about 6 hours there getting my sugar back. And my doctor said, I was trying to explain to him that I was at the emergency room, and I said, yeah, I have a heart problem. He said, oh, that doesn't have anything to do with your heart. I was just wondering.
Yeah, at that time, if it did not affect it at that time, then it did not do anything. As I said, most of the times it does not, but it can. And you're very lucky.
Well, I understand that.
Mm-hmm.
Okay, well, I was just wondering because it didn't make any sense to me if you have a heart, heart trouble, and you go through a seizure, and you sit there flipping and flopping and unconscious, and
Yeah.
I thought it wouldn't be good for your heart.
It definitely is not, but it can induce an event or not, and in your case it did not, which is a really good thing.
Yeah. Okay. Well, I appreciate talking to you, Doc.
Thank you.
All
Thank
right.
you very much.
Thank you
Thank
so much
you.
for calling, Jerry, and we're happy that everything turned out okay. That
Yeah.
really is a concern, I guess, when you already have what's called a bad heart. Anything can affect it. But that was interesting that you said if it was going to, it would have affected you in the moment. It would have happened
In
there.
that specific event,
Yeah.
it would have affected in the moment.
Mm-hmm.
But having long-term effects from that is probably not
Mm-hmm.
something that we see very well.
And if someone is walking around with what they're told is a bad heart, that term, is that a broad term for what could be going on? Does anyone really have a bad heart? Or
Well, it's not.
once you've had damage?
I would say it's not a very scientific term, but it encompasses a lot of things. It can include like heart failure, it can include coronary disease, it can include a lot of things.
Okay.
And and that's when we investigate more when we hear the word bad heart. But hopefully, hopefully bad heart can turn into good.
Can turn
these
into good.
days.
So once a heart is damaged, like if you have a heart attack or something and it damages the heart, does it stay damaged, or is it like any kind of muscle where it can get better and stronger and heal itself? And
Well, great question. It depends on the extent of damage.
Okay.
So if, like what we were speaking about heart attacks, if heart attacks are, you know, if you go to the hospital at the right time, you don't ignore your chest pain, and you get it fixed right away, the amount of damage is very, very minimal. It might not affect it at all. If you delay, think it's just dyspepsia, it's just nothing, and then turns out to be a heart attack and time passes, it's a muscle, and there is a saying, you say time is muscle, so every time it's like you got some muscle fibers die. But that's not the end of it, because a lot of times if we intervene in a reasonable time and we get blood flow to the heart, the amount of damage that is done can be compensated. And with current medications and everything, I mean, the heart can do pretty well.
And you said specifically you were really drawn to this when you lit up when we were talking about ways to help people. And what brought you to this specialty? What is it that you found so interesting and about coronary disease?
Well, so I have a surgical background, and I used to be a surgeon, and honestly, it's a lot of invasive things to do. Open people up and cut people up, and I mean, sometimes it's absolutely needed, but with the advancements of this that I have heard about since I came to US, I was really drawn to be able to, help people through less invasive approaches. So instead of cutting you up, you just go through arm or the leg and, fix it, do the same thing. And and you can say, a passion for, helping people that are, told, well, you cannot be helped. It's very gratifying.
I'm sure, and we're very grateful too that you're here with this, especially this program, like you said, is 1 in 5 in the country?
Yeah, the training programs is like the organized training programs is just 1 in 5 in the country.
Right.
And we hope to grow it. We hope to make this a more, more available to everybody, and that's our role. So I'm very involved in writing on the topic and on writing the books on the topic, and a lot of research as well, and the teaching physicians on the techniques on how to do that, and what are the terms, what are the tools, how to use it. So it's like our goal as a community is to make this available to a lot of people.
Yeah, because like you said, physicians and surgeons are always training, always learning.
That
and
is
luckily
very
there's
true.
so much information out there. And then what you do is with every patient you treat, that's research right there. So then it's able to teach and write and document everything that you're learning, and it just all works together in this huge network of healing between physicians and surgeons. Always learning, always teaching what you've learned, right?
Exactly.
And we get to benefit from all of that.
Helps everybody.
So tell us what these treatments in this program actually does offer. So our viewers here in Shreveport, Bossier, and all over the Arklatex, all of our viewing area are hearing about these advanced treatments. Let's start with, you want to start with first, like what this disease, how it's diagnosed, or how this comes about before the treatment actually happens?
So it is diagnosed the regular way. Coronary artery disease is diagnosed, chest pain, shortness of breath. Most people undergo some stress test, and they undergo an angiogram, and they found very, bad disease, or, then they are either offered surgery for that, and they are told, your disease is too extensive, you need surgery. And most of the time surgery has a lot of great benefits, but sometimes people are not candidates. They cannot undergo surgery, they are older, they already had surgery before, so doing a redo surgery is very, very risky. Have like other disease like kidney disease, liver disease, lung disease, so they cannot undergo surgery. At this moment, when you don't have the surgical option and you have very, very complex disease, the option is, well, is there someone able to do this, or will we just give you medicine and that's it? That's how it's diagnosed. That's how it comes about. And then according to the community, what's available, what are the tools available, this determines the fate of the patients. And the tools and techniques that we use are like so extensive, but most of these can be treated with a percutaneous approach without surgery.
Without surgery. So what are some of the advanced treatments?
So the regular treatments for coronary artery disease are like balloon angioplasty, which is going in, crossing that lesion, ballooning it with a balloon, opening flow, and putting in a stent. So that's the regular treatment. The problem with complex disease is that it is either very difficult to cross it or get around it. It is very difficult to balloon it because it's very tight and tough and calcified. Or it is like 100% occluded, which is not the way a normal wire can go. So what we do in these situations is that we can attack this occlusion from both sides. So we use like 2 catheters, and we go around through the small channels in the heart and try to make a connection. And then when we make a connection, we can place in a stent, and the vessel should be open. So yeah, and these techniques has been, being, developed in the last 2 decades, 3 decades, and it's been amazing how we got so far. We can do it with lesser catheters, we can do it with smaller catheters, we can go around things that were like impossible to do years back.
Yeah, that's incredible.
Yeah.
Yeah, and so say you are going in, so it's like one vein or artery, and it's the catheters coming from each. So how does that happen? Is there an incision? How do you what are the tests first to find out where the occlusion is?
So we find it by an angiogram. So just the regular angiogram you have when you have like a post-stress test or chest pain, and that shows us like everything in the heart and where the arteries are and where the occlusion and blockages are. And then at this point we decide, we spend a lot of time on developing this strategy. It's like a code. So they say you should spend like 20 minutes looking only at the just looking. And then we decide on which ways to go. We decide which channels are supplying this vessel, and then we try to go with 2 catheters and use special wires, special microcatheters to go around these small channels in the heart, trying to get it from the back and then try to connect. And yeah, it can be lengthy.
I'm sure.
Yeah.
That's incredible.
Yeah.
And so if people don't know or they're not familiar with what an angiogram is, describe how an angiogram is
so
done.
An angiogram is basically a test where we get like a small tube in either the groin or the arm. We go to the heart with a tube, and then we selectively go into the heart arteries and shoot a dye. And under X-ray, the dye shows us the coronary arteries or the heart arteries. And it's like the best test for seeing the arteries and seeing what is going on with them. So it has been there for so long, and it's still the best.
And this is with dye. Has the dye itself been improved also? What is it about the dye? Does it light up? Does it know where to go? What is special about this dye?
So this dye is what we call radiopaque, meaning if you put it under X-ray, it gives you a very, very distinct view. It's black, and oh my God, it has been advanced so much. In the past, there is like dye that can give you a lot of allergies. It was very thick. It can hurt the kidneys much. And in the last like 12 years or something, the advance has been great. Now the risk of allergy is very low, and the amount of contrast that we give is going higher because it does not still affects the kidneys, but not as before. Like everything is advancing and like in all our benefit.
That's really good to know too, because I never thought about the dye causing anything or it not being very healthy to even have that done. So I'm sure that's always a choice too for the patient, to understand all of that,
Of course.
And if they say, I don't really want dye injected, is there another way? Do you find out? Are there alternatives or another way to find out if they don't want that?
So yeah, it's a science of itself. So if we are like more than 90% sure that this is coronary artery disease, the best thing is to go for an angiogram.
Right.
The best thing, because that's what shows us what's going on. If the possibility is in the middle or lower, we can do a stress test, and if the stress test is normal, you're fine. Then most of the times you're fine, and There is no issues with that. But if it shows something, the end result is getting an angiogram still.
Right. And you
So-
have to weigh the odds too, because
Yeah,
you're really trying
exactly.
to save your heart.
Of course.
And there hasn't been, that much that we say that the dye is going to cause,
No,
it's
not
definitely-
in these days at all.
Especially when
we pay close attention to the amount of dye we give. Close attention.
Right.
And we never give an amount that, hopefully most of the time, we never give an amount that is higher than what the kidney can tolerate.
Yeah. So very much lower doses, and it's much better too. It's
Yeah,
improved too. So
that is very
not
true.
to worry if you're someone who Googles the internet and tries to find all that kind of stuff out. And very safe
Yeah.
procedures. Another advancement. What else can you tell us about the advances in this program?
Well, I can tell you we are trying to bring that to Shreveport Bossier, and we have actually done 2 patients already with chronic renal occlusions in the past 3 weeks, and they are doing great. And there are a lot of people here that need help.
A lot of people
So,
here need help.
Yeah.
Well,
a
we're
lot
glad
of
you're
peop-
here.
A lot of people need
Yeah.
help.
So what are the kind of things that we can do to, is there anything we can do to prevent this? Is there a lifestyle that we can live? Do we need to pay attention to if we have it in our family? What are the kind of things that you see that this comes up in certain patients?
Well, I'll tell you the short answer is that there is no one single thing. It is a lot of genetics and family history that can cause this. And this we don't have. Age we cannot control. But what we can control is what we eat and our activities. I think that is the most important thing. Like what we eat, salt, fried food, less veggies and fruits, all this specific diet is associated with bad coronary disease. And of course inactivity and not exercising. I think these 2 factors can summarize it all.
Yeah. And would you say that's just the answer to get out ahead of anything? Like get as healthy as you can
Exactly.
first. Just make that, and it means in moderation. We talk about this a lot here, especially living in the South, because we got this great fried food.
Yeah.
And sometimes, like now, the weather it's too hot. I mean, it is dangerous to get out and try to exercise. You might overdo it. I mean, there are all kinds of things that fall into the conditions and the cultures and where you are. So what's the mindset? What do you tell someone when they say that, all of these things that are coming up?
Well, great question, and it depends on who I'm talking to. So I was recently talking to a very nice gentleman, and he says, just love potato chips. And I cannot stop eating potato chips. I told him, listen, I won't tell you to stop it, but if you're eating 2 bags, I ask you to eat 1, and let's see in 3 months. I mean, it all starts with small steps. You can never turn into a vegetarian,
Overnight.
athlete overnight. It cannot happen.
Wish we could. That'd be great if I could just, wake
Yeah.
up and already be like, yeah.
Yeah,
this
it's
is
not
great.
about it. It all starts with small things. You eat a lot of salt, reduce a little bit. If you don't eat veggies at all, just start with 1 thing. And it starts like that.
Do you feel like that's come a long way too? Because it seems like back in the day, it was be like, don't do that.
Yeah.
Cut out all your salt, and because
Yeah.
that was really all we really knew. It was the terminology a long time ago, and this is like
Exactly.
30, 40 years ago, and doctors, physicians, everybody was doing the best they could and just saying, you know what, just don't eat salt, don't eat fried foods, don't eat, and now it's so much better. It's like we understand we're human. And if you do cut something all the way out, do you find if a patient does try to cut something out, they're just going to replace it with something else that
Something
might be
else.
equally as dangerous?
Well, it depends.
Yeah.
It depends as well. And again, it depends on the individual. And I think your question is very smart.
Thank you.
Your question is very smart. And your point as well, like we discovered that if you tell someone to just don't do that, they will not listen to you, which is very understandable. I mean, it took us a lot of time, a lot of psychology research to find out, but it's very intuitive, right? So when you tell someone to cut out something or turn down, some of what they're doing, yeah, you gotta be careful you're not introducing another harmful thing, of course. and that's part of the overall discussion. And I think people now understand what is it that they need to do. They just need a little push, you know.
Need a little push.
Yeah.
A little push and support.
Yes.
And it's nice to hear too, I'm sure, the patient, especially if a patient comes in worried about heart disease or any kind of blockage or anything with their circulation, anything like that, that's such a mystery to a patient, to hear moderation. I love that you said, you know, I like chips too, but if you're eating 2 bags, how about we just eat one?
Yeah.
You know,
Yeah.
one bag, even if it's one big bag, just
Yeah.
one.
Just one and revisit in 3 months. I'm not saying keep eating
That's
one.
right.
Yeah.
And revisit. Let's keep
Yeah.
just keep checking.
Exactly.
Which is really nice. And I think, do you see that it takes a lot of the shame too out of it too? Like people come and they're embarrassed because maybe they've lived this lifestyle or they feel like they don't walk enough when there's so much pressure out there to
Of course.
be athletic, not just fit but athletic. And I think we have another call. What's the name? Vera?
Vera.
Hi. What is your question for the doctor?
I have a question. I'm trying to see, like, if your chest is hurting, like you can't. It's like somebody smothering you in your chest. Is this? I just caught the ending of what y'all talking about. So is this part of my question?
Did you hear it? There's a symptom, I think you heard, like it feels like someone's smothering you on your chest. That's what it feels
that-
like to you?
Yes, like I've been complaining about my chest for the last week.
Oh.
Yes, I've been complaining about my chest been hurting. I do have a big blood clot in my lung,
Oh.
and I was in a bad wreck last year.
Oh.
So the term that you're using is smothering you in your chest. That is a little concerning, and most of the typical pain that comes from the heart is described as this pressure smothering, an elephant sitting on my chest. It is like it is kind of typical. I recommend that you get checked as soon as possible.
Okay.
Yeah.
Does that answer your question, Vera?
Yes, ma'am.
Okay. All right. Good luck to you. I hope you get checked and you feel better. And I'm sorry about your accident. And thank you so much for calling. And so that is another thing, talking about feeling smothered on the chest. We've heard before it's like an elephant is standing on our chest.
Yeah.
You know, those kind of, and it's hard for us to describe too. Do you suggest that we just come in and just tell you, not try to
Of
sound
course.
too, knowledgeable, really just tell you exactly how it feels?
Yeah, and another important point, this typical pain, it happens in a certain percentage of people, but otherwise people might not think it's the heart. Sometimes it comes with just shoulder pain. Sometimes it comes with some, especially in women, it just comes with feeling of dyspepsia or something, and I'm not feeling right. And and people usually ask, how do I know if this is just dyspepsia or something? And I mean, the easier way is, take a dyspepsia medication. If it doesn't go away in half an hour or an hour, I mean, you should be a little concerned that it might not be just dyspepsia. So being alert, having people understand that this can be a symptom is very important.
Right, and don't be afraid to ask. Don't be
Of
embarrassed.
course.
I mean, it'd be great if I came in and think I'm having a heart attack and you said, no, it's just a little bit. You're okay, it's indigestion.
I totally
would
agree.
love to hear that. And so we need to not be embarrassed if we come in and we think we're being overly dramatic. There's no such thing with your health,
100%,
right?
100%.
Yeah.
I mean, if you're a little concerned, you should get checked.
Definitely get checked.
Of course.
Yeah. Well, thank you so much. What else would you like to leave our viewers with today about this condition, and what do patients need to know?
Well, as you said, it's very important to prevent it in the first place and take steps while you're healthy, not take steps when you are diagnosed. That's very important. And it can be very, very scary, but as I said, it's come a long way. And advances in everything, not just techniques, in medications and everything. It's keeping it should not make you scared, and you should get checked, and hopefully these days we can make people live better and healthier.
Yeah, definitely better and healthier. Well, thank you so much. This has been a very helpful and hopeful discussion. So thank you for coming here today. It's been such a pleasure meeting you and discussing this.
It's a pleasure.
All right.
meeting you.
And thank you for watching, everyone. We'll see you next time on Healthline 3.